Oh, oh, this is not gonna work.
Oh,
Oh,
interesting.
hold on a second. I need to get rid of this. Um, hold on. You need to guide me through it.
Go ahead and introduce yourself.
Hello, everyone. My name is Sergey Motov. I'm the attending and research director at beautiful Department of Emergency Medicine at Maimonides Medical Center, Brooklyn, New York.
Motov, we're going to talk about pain management today, obviously. So I just want to put forth this scenario of being in the department and having my nurse come up to me and say, "Hey, Duncan, I got the bloods on that guy over in bed 14, and I had the line for a second, but then I went to flush it. The line's no good anymore. It's super infiltrated. He's a wicked hard stick. I don't want to have to poke him again, but he's asking for something for pain." I wanted to start by talking about oral analgesics, and I feel like this is something I reach for a lot, but it's also very narrow. I feel like I'm reaching for ibuprofen 400 milligrams because I know you'll yell at me that the ceiling is 400,
I will yell at you.
Or I'll give a gram of Tylenol, and then after that, I'm kind of like, oh, I kind of wish I had an IV so I can give some morphine. That's my typical escalation. What other PO meds are you giving in the department for pain control?
Ibuprofen is a good start, either alone in combination with acetaminophen, even though most recent data seems to be disproving the fact that combination works better than single agents alone. And we can always consider using oral opioids. And my favorite opioid is moral sulfate immediate release. You start at 7.5 milligram as a single dose in someone who has, let's say, even a fracture. You can combine this opioid with ibuprofen. At least initial approach, you may be able to alleviate some pain at level the patient might be willing to accept. So oral opioids in combination with NSAIDs, so ibuprofen and MSIR. In addition to it, let's say a patient has a headache, you can still start with a combination of oral ibuprofen, acetaminophen to that extent. You can prescribe oral antidopaminergics such as metoclopramide. You can give 10 milligram of oral metoclopramide and see what's going to happen with the next 20 to 30 minutes. Severe pain, all bets are off. I need something more definitive, something more rapidly and more effectively acting from the get-go. Things that drives me crazy, but people still prescribe so-called muscle relaxants. You can give them orally, right? Methocarbamol, cyclobenzaprine, the list goes on and on and on, even though they don't work. You have some spasm and people believe in oral benzodiazepines. Again, they don't work, but there is some armamentarium of oral muscle relaxant, even oral Benadryl to that effect, antidopaminergic, and NSAIDs, opioids. You do have enough medication, at least 5, 6 to begin with.
Okay, so you're really focused on sort of the type of pain they have, and that sort of guides. It's not algorithmic for you. It really is catered to the patient and what type of pain they had.
You're choosing patient based on their presentation, the unique presentation, not because you have some sort of algorithm that really applies that one pill fits all. No, it's outdated and it's orthodox approach to pain. You have a patient in front of you, tailor it to their need based on what you wanted to achieve.
Do you want to make a plug for your CERT mnemonic?
CERTA, sure. I like CERTA. Channels, enzymes, receptors, targeted analgesia. The concept based on the premise that we're moving from sort of symptom-based approach to pain to mechanistic. And as the name implies, this CERTA concept will allow us to combine analgesic of different classes, act on different target sites, such as receptors, channels, and enzymes. And that synergy, in theory, and frankly in practice of my 15 plus years of working as a ED attending, really shows superb analgesia in comparison to each analgesics alone.
I'm going to move the scenario into a patient that's really uncomfortable with their pain, writhing in bed. Perhaps they are holding their flank and vomiting a lot, and they're not going to be able to take anything PO. Can't get an IV on this person. I would love to be able to stick them with something intramuscularly. What are your thoughts on that?
Well, you're just about to open up the Pandora box. There are a few pet peeves in pain medicine when I have, and this is one of them. I have a huge aversion to IM route when it comes to analgesics, and I'll tell you why. The concept of inflicting pain in order to control pain never sits well with me. Have you ever had anything given to yourself IM? Tetanus, vaccine, anything? Have you ever had ketorolac given yourself IM? I've tried it once just to experience what it's like. It hurts. So the question is, why would I give more pain to a patient who might benefit from different routes? So pain is very unacceptable to me when you use IM. Second, absorption rates. Everybody got different level of muscle tissue and subcutaneous tissue. You need to be assured that needle actually gets into the muscle. And even if it gets to the muscle, what are the rates of absorption? It could be 20 minutes, 30 minutes to 45 minutes. All this anecdotal evidence, you give shot of Toradol and 5 minutes later, patient miraculously better, it just doesn't work this way. It takes good 37 to 45 minutes to get better. That's why IM injection of ketorolac have exactly similar answer for answer with oral. Thirdly, specifically with the opioids, repetitive injection into the muscle of opioids lead to aseptic and septic necrosis. Patient can develop neck fash. But more importantly, as the time goes by, your muscle tissue gets replaced by connective tissue, and you develop a condition called myofibrosis, which means that you have no vessels left in this very connective tissue to get that medication that gets injected to the muscle and give you some relief. Leads to dose escalation, higher the dose, higher the side effects, and then it becomes a vicious cycle of perpetuating use of opioids. You know what's better than IM?
What's that?
Skin. People tend to forget that skin is the largest organ in the body, and subcutaneous injection of opioids work just as good as IM. Frankly, even better. The dose is essentially the same. I would not change much of anything with opioids. If you use, let's say, fixed dose of morphine at 4 to 6 milligram, use the same dose subcutaneously.
Is there a life and death sort of scenario in your head where you're like, we got to reach for IM analgesics here?
In a situation, let's say somebody is trapped, right? Crash injury, or they're getting an amputated limb, and you can get to them with the IV. And the thing, we have a little piece of muscle sticking out somehow. You may get access to it, and you can inject the opioid on NSAID. I would take it.
I know you want to talk about some intranasal medication, which I think of intranasal fentanyl or intranasal like Versed or something. I'm immediately thinking this is pediatric procedural sedation. I've never used this medication in adults before. Can you talk a little bit about that?
Absolutely. Well, you pointed out correct. Majority of literature always comes from pediatrics. Either it's EM, trauma, surgery, hemonc, what have you. It can be opioids, intranasal fentanyl, intranasal hydromorphone. It can be benzodiazepines for sedative procedures and such. It can be intranasal ketamine for pain, procedure, and sedation. The list goes on and on and on. On the adult side, they're not as robust data, but it can be utilized. It can be used. And frankly, there's nothing to lose. Have somebody who's suffering, and there is no other means or ways of giving him analgesic, utilize the nasal cavity.
Can you talk to me a little bit more about the actual specifics? So a patient comes in and they're complaining of pain, and you say, I really want to give this patient intranasal analgesia. What drug do you reach for, and what dose do you reach for?
So intranasal, I would use for fentanyl if it comes to opioid, and the dosing is 1 to 2 mics per kilo. So on adult patients, we're talking about somewhere between 75 to 150 microgram of fentanyl as a single shot. You can split between 2 nostrils. Intranasal ketamine, 1 to 1.5 milligram per kilogram. So again, it's about 100 to 125 milligram split into nostrils. You can give it to a single person. There is an intranasal ketorolac available on the market, but it's super expensive, and I personally don't use it because, me and ketorolac.
How about topical NSAIDs?
Well, I love topical NSAIDs. This is probably most underutilized modality that we could make a huge difference in people's well-being. Remember, NSAID should be given for the short period of time with the lowest effective dose. NSAID's not a benign medication. Heart and kidney and drug-drug interactions and what have you. Especially now with Voltaren or diclofenac gel becoming over-the-counter medication, don't get me wrong, it's still expensive, but you can make a difference. Simple statistics. If you have a bad knee, arthritic knee, and you give somebody ibuprofen, you get maybe about 10% of ibuprofen from systemic circulation going to this knee. But if you slap a flector patch, or you give diclofenac patch, or you give diclofenac cream, it's about 6 to 75% of this medication. It's actually going to get into the cartilage. So bioavailability and absorb, it's much, much better on a local tissue level.
If someone came in with musculoskeletal injury or some sort of somatic pain like that, and you were like, I could either give them 400 milligrams ibuprofen Q8 hours, or I can tell them to put on topical NSAIDs. Is there a preference? Is one better than the other?
Well, I would probably go for topicals because, I always give NSAIDs no more than 3 days. Another option is to give them 3 days, either single agent or in combination with what have you. And if pain is not getting any better, you need to switch them for something else. So, but if you want to say go a week worth of medication, it's got to be topicals.
All right, I'm going to let you do it. I'm going to let you talk about BAN.
Oh, BAN. See?
You want to take your background down so we can see your toys?
Oh, absolutely. So once again, another not so often used modality, which has become one of my favorites over the past 3+ years or even close to 5 years, is a nebulized route of medication administration. And I'm going to show you, this is a breath actuated nebulizer. As you can see, it differs slightly from the conventional nebulizer because it looks like it's a closed canister. It's a closed canister. It has an inhalation port, has obviously your source of the air or oxygen. Within there's a liquid medication. So prescribe. And the way it works is very simple. 2 points. You dip the medication in and you have this beautiful topping. You just seal it on. And the reason I like it so much, on top of it, if you can see, there's a green button, there's a chambers, and there's a reel that you can switch between 2 different modes of action. Breath actuated nebulizer works as a continuous nebulizer, as we're accustomed to. Problem with it, you lose lots of drug to the ambient air. And if you're next to the patient giving him, let's say, opioids, there's a chance you may get slightly fumigated by fentanyl or morphine vapors, and you can get a little loopy, lightheaded, and it's occupational hazard. Should you switch to the different mode, it turns to be on demand, meaning patient takes the breath, medication gets released. Patient doesn't take a breath, nothing happens. At this point, systemic bioavailability gets a little bigger and nothing gets into ambient air. So let me show you how it works. I'm just going to turn the oxygen on.
You're plugged into a regular portable oxygen tank right now?
Or air. So as you can see, vapors are coming out, right? You see the vapors?
Mm-hmm.
So this is a blow-by or continuous infusion. And you can see there is a switch with a little green button to it. So if I turn switch counterclockwise, say it just stopped, nothing vaporizing. And what happens is I'm going to be as a patient show demonstration-wise. When patient takes a breath, there's a green button. It will be depressed, and medication gets released. Patient stops breathing, nothing happens. So simple demonstration. So once again, every time patient takes a breath, this bottom goes down and you get this amount of medication. You stop breathing in, nothing happens. That's why I like this, because it's called sort of nebulized patient control analgesia. Patient is in charge of their own medication. You can breathe as fast as you can breathe as slow as you can. But as long as you're taking a breath, you'll be getting some medication. Another thing is, overdose is essentially impossible for the sense, because should patient become loopier, they won't be able to trigger the breath, which means medication is not going to get released, right? Neither to the patient to ambient air. And just simply fall asleep, medication falls off, and that's it. So the initial studies really cover fentanyl. Dosing mother slightly larger than intranasal route. We're talking about 4 mics per kilo for adult and 2 to 4 mics per kilo for pediatric patients. And again, it's non-invasive, it's titratable. You can go up to 3 or 4 doses if you need to. Highest I've ever gotten was 3 doses in succession, and patient did feel better. Morphine. Pediatric patient, we do weight-based 0.2 to 0.3 mg per kilo, and adults, studies actually rooted for fixed dosing. 10 milligram fixed dose or 20. At 20 did better in the patient with acute musculoskeletal injury. So 20 milligram of morphine into the band, up to 3 doses, and you can get some appreciable relief of pain. Recently, we've been using ketamine. There isn't a consensus on dosing because there's no data in the emergency medicine world what constitutes the best dose for nebulized ketamine. I'd probably push it plug for somewhere between 0.5 mg per kilo to 1.5 mg per kilo. And it's the same principle, titratable, reassess the patient on appropriate interval of time. And this is a nifty tool, can be utilized at triage. And that will buy you some time to alleviate somebody's suffering until you determine the patient needs definitive accesses. So breath actuated nebulizer.
I'm trying to think, is there anyone we shouldn't be using ban on?
Facial trauma probably would be one I would not push forward, whether oral or facial or nasal-orbital, what have you. And simple refusal of the patient who cannot comply with the simple rules of how to use nebulized medication.
Any other last-minute take-home messages that you wanna give out?
This is my biggest pet peeve when it comes to pain management. As you know, just please engage patients in shared decision-making. Talk to them. Tell them what you're going to do. Offer them this beautiful armamentarium, what you have, by medication, by route, by tools. Just tell them exactly how it's actually going to work. And don't camouflage a thing. And please don't focus on zero pain. It's not real. Set an expectations. Tell them you have a broken bone, it's going to hurt. They follow the natural trajectory of the painful syndrome is very important. So be honest with the patient, but at the same time, offer them everything you can offer. They will love you, you feel good about yourself, and ultimately you'll be able to control the pain.